Right, good afternoon everyone. I make it 5 o'clock, so I'm going to open the meeting. So, agenda item 1, evacuation procedure. A fire drill is not expected, so if the alarm does sound, please evacuate the building quickly and calmly. Please use the stairs and do not use the lifts. Once out of the building, please gather outside the Yorkshire Bank on the opposite side of the road. Exit by the door by which you entered the room or by the fire exits, which are clearly indicated by the standard room fire exit signs. If you do need any assistance in evacuating the building, please make yourself known to a member of staff. I'd like to also take this opportunity to remind everyone to turn your mobiles off or set to silent, please. Agenda item 2, I've received apologies from Councillor Walmsley and we have Councillor Llewellyn-Nash substituting. So moving on to agenda item 3, I'd just like to confirm the minutes of the meeting held on the 4th of July, detailed on page 6. Councillor London?
Sure. I'm not quite sure that it's accurate in EO4, future of primary care. When Jenny Northgate gave us the information on GPs and said there was an 85% satisfaction rate, a number of us queried that, especially me, with regard to specific GPs. And it did appear that the good high-scoring GPs were actually dragging up the not-so-good, and the lower-scoring GPs to give an average of 85%. And I think we ought to know the GPs that are not performing that well according to their patients. And in fact, not just us, but the health and wellbeing board should know that. So it's a bit of that. And it's not reflected. All it says in the minutes is that existing challenges to accessing services at one specific GP practice in the borough and the contractual means to address that poor performance. So it doesn't actually specify, and Jenny did say that we could have a copy of the actual individual scores, and they haven't come through.
Okay, are the members that were in attendance at the last meeting happy for that change to be made? Other than that one amendment, are we happy with the minutes? Okay, moving on to agenda item 4, declarations of interest. Is there any member with any declarations other than those stated in the paperwork? Councillor Hoffman.
I'm also a member of the Communication Workers Union.
Okay, thank you. Any other member? Okay, moving on to item 5, public consultation. I've been made aware of one speaker, Mrs. Condacor. I don't believe she's here yet. Okay, moving on to agenda item 6, Health Watch. So we're going to hear a presentation by Mr. Chris Bain, the Chief Executive. Afterwards, if the speakers arrive, we'll hear from the speaker and then we'll take any questions and comments from the members. So we'll pass over to you, Chris. Thank you.
Thank you, Chair. Good evening. Earlier on today we had our annual conference in Leamington, and we heard from Rachel Danter, who is the Transformation Director of the Coventry and Warwickshire Health and Care Partnership. And she was talking about the NHS long-term plan. So I thought that part of what I needed to do today was to make the committee aware of the main parts of that plan and to urge everybody to get involved in the consultation that is currently taking place. The consultation on the long-term plan started on the 27th of September, but it only runs through to the 15th of November. So if you're going to get any kind of statement in, it needs to be done fairly quickly. We as Health Watch will be submitting a formal response to the consultation. But I'm also going around now, and at every meeting I go to, urging people to get involved in this because it is significant. It is a huge thing that's happening. So what I did was to draw out the key elements of the long-term plan. Now the long-term plan is, it's a response to a whole series of things that are happening, primarily in public health. And we talk through some of those today, and some of them are largely related to an ageing population. A population that's living longer, but it's not living healthier. And because medicine has improved, what it means is that older people are living longer and longer with complex long-term conditions. And that's what's putting pressure on NHS services. It is, in fact, we are victims of our own success in that regard. So we've been working with the Health and Care Partnership, and they're coming up with this long-term plan that is now out for consultation. And the key elements of it are over the next couple of slides. But after that, there are some suggestions I would make for getting involved in the bits that really matter. Because a lot of these, it's really hard to argue that prevention is a good thing. It's really difficult to argue against that. Of course, it's better than cure. So they're talking about prevention, they're talking about integrating care, they're talking about making urgent and emergency care better, and of course giving more resources into mental health. And cancer earlier diagnosis, I mean, who is going to argue with any of these? They're worthy objectives, but I actually think there are other things that we need to get involved in. Maternity and paediatric services are out for consultation as well. I think it's really important. This review of maternity and paediatric services has been going on for quite some time. And I think people are making their views known, but we are getting close to the point where it's going to be finalised. So if you want to have a say in the way maternity and paediatric services work, and the bit that we're focusing on is having the same midwife throughout your pregnancy and beyond, so you have a continuity of care. And I think that's part of the safe and sustainable services. But if people don't make their voices heard, then it will simply proceed the way it is. They're talking about efficiency and value for money. Well, again, difficult things to argue with. And population health. There is a new process in town called population health management, which is a term that we will increasingly hear. And part of population health management are what are being called the wider determinants of health. And some of the responsibilities that you have as a district council are amongst the wider determinants of health. So housing is the obvious one, but environment, planning and other things are another part of it. So I think when the Health and Care Partnership is talking about population health management, I think they're assuming your cooperation. And I think you need to get involved, if only because of that. To say, actually, there are issues here in Nuneaton and Bedworth which require your particular attention. I did look at the JSNA, the Joint Strategic Needs Assessment for Warwickshire North, before I came here. And there are a series of things that are identified in Warwickshire North that are different to the other parts of Warwickshire. And one, if I could make a plea to get involved, to say that let's get those things. I used to live in Warwickshire North. I lived there for 17 years, so I have an understanding of some of the challenges. What I would want to see is people getting involved so that the specific challenges of Warwickshire North are addressed by the long-term plan. And the long-term plan involves the spending of £1.4 billion of public money. And so I think it really does need everybody's involvement. We're going to get fully involved, and we're encouraging our third sector partners and local government partners to get fully involved as well. But these are the bits that I think it's really important that we get involved in, because they're the front line. The engagement period, I've already indicated the 15th of November is the time period at which the Health and Care Partnership has to submit its plan to NHS England for approval. The reality is, if you want to get significant changes to that plan, you need it at least a week before that, or else it's not going to get incorporated. So you've literally got about 2 or 3 weeks to get involved in this. And I would urge people to do it if they can, either as an individual, as an authority, or as a community. People should get involved in this. Are people familiar with the terms further down, integrated care systems, place and primary care networks? So are people familiar with those terms? Because those are the way in which this entire system is going to be designed. So the integrated care system will be Coventry and Warwickshire. That's the footprint for the integrated care system. And the integrated care system is designed to bring all the partners in health together, including the NHS, county council, district councils and the third sector, and in some cases the private sector, to be involved in that integrated care system. So that's a Coventry and Warwickshire footprint. Within that there are 4 places. One is Coventry, one is Rugby, one is South Warwickshire, and the other is Warwickshire North. So Warwickshire North, including Nuneaton and Bedworth, will have its own place, and it will have its own place executive. And I would be challenging to say who is sitting on that executive in our place, because they are the ones who will be making the commissioning decisions about how services are delivered in Warwickshire North. So place, we'll have heard this before, place is a really important part of the integrated care system. But where the patient voice is most likely to be heard is in that next one down, primary care networks. Now, primary care networks are groups of GPs who will work together to serve a population normally of between 30 to 50,000. And there are going to be, I forget how many primary care networks in Warwickshire North. I think it's 7 or 8, something like that, across the whole patch. And primary care networks are, the money that is going to be spent on primary care will be devolved down to the primary care networks, who will then make decisions about how it's spent. So everybody needs to understand their primary care network, who its director is, and who its clinical directors are, because they're the ones who will be making the decisions on how money is spent for the people in your wards. That's where it's going to happen at the moment. And the commissioning arrangements are, I think, still in the air slightly. What the long-term plan talks about is a single strategic commissioning function for the whole footprint, which is Coventry and Warwickshire. And it will then devolve money down to the place executives and then down to the primary care networks. So we need, collectively as patients, to be involved at every level if we're going to get our voices heard. And I've put at the bottom the email address. If you want to have a say on this, that's the email address to use. I did check it out today, and if you write to them, there is a response to it. It's also on the website. So that's the NHS long-term plan. It's happening now. One of the reasons I'm urging people to get involved is that if we do nothing in health and social care, if we continue as we are, there will be a £100 million deficit. So they are going to have to make changes to recover that £100 million deficit. And I don't want them doing that in a way which disadvantages people and patients. If they're going to make a £100 million reduction in spend, then I'd rather they did it on backroom functions or things that don't directly impact people's welfare. So I'm happy to take any questions on the long-term plan before I move on to the other things that are happening at the moment.
If you'd like to finish your presentation, then we'll take all the questions at the end. Thank you.
The Care Quality Commission has issued their annual statement, which is called the State of Care. It is an excellent document. It always is every year. And it brings together some of the key highlights, many of which, when I look at them, I immediately recognise them. And some of the things about the care that is being experienced by people with learning disabilities or on the autistic spectrum have been traditionally fairly poor, and the CQC are saying that that remains the case now. All care services, I indicated earlier, are under severe pressure. That's partly demographics. I think that when you have people living longer with multiple long-term conditions, it does put pressure on any service. There is instability in the adult social care market, and we have had examples of providers giving back their contracts because they can't afford to run them. And I think the rest are I think are fairly common sense. We would like to see care being given closer to home. Community services are needed. The final one is a long-term problem that I don't think will be solved easily. It is the workforce problem, which is being experienced both in social care and in the healthcare sector. And I think what we have to do is work collectively to make Warwickshire a really nice place to live and work, so that people are attracted to come and to work for the health and social care services here. So it's a long-term issue. We looked at the shortage of GPs during the GP task force last year, and I think there are going to be significant shortages unless we begin to address some of the training issues. 40% of male GPs in the UK are over the age of 50 and looking to retirement, so we're going to have to deal with some of that at some point. And we have nursing shortages, and we have social care shortages. So it's going to be a long-term thing. But I'm actually, surprisingly, quite optimistic about it, because I actually think health and social care services, I mean, the fact that the population is ageing means demand for health and social care services is not going anywhere, and it's a long-term career. What we have to do is to make sure that it's a welcoming career as well. Moving on briefly to stroke services, there is a consultation out on stroke services at the moment, which is running till January 2020. And the proposals that are on the table at the moment are that the acute services regarding stroke will be located at the University Hospitals Coventry and Warwickshire and the Walsgrove site, which makes sense because that's where the diagnostic equipment and the specialists are. Hospital-based rehabilitation will be at the Leamington Spa Rehab Hospital or at the George Eliot. And there will be an early supported discharge service is the idea, so that people can be treated at home. And that's partly the community stroke rehab as well. Other things that are happening. The Mental Health Trust, Coventry and Warwickshire Partnership Trust, have issued a document in which they are proposing to make changes in the use of their estate. So the Caledon Centre now, all acute mental health services for older men and women will be at the Caledon, and the PICUs, the psychiatric intensive care units, will be located there as well. The primary focus at St Michael's in Warwick will be on older adults and frailty, and the dementia inpatient services will be based at the Manor Road Hospital in Nuneaton. Now these proposals are not new, but they were confirmed earlier today in writing, so they are the ones that are going out at the moment. Turning to what Healthwatch has found, as opposed to what other people are doing, I look back over the queries we've been having over the last, and I've gone back 6 years, and these are the 4 primary areas that people are telling us they have concerns about, and it's been fairly consistent. We looked at quality of care, and that can relate to things like waiting times for assessment and referral. It can look at staff shortages. I mentioned earlier about the workforce issues. And the use of agency staff is one that's come up a number of times. And in some instances in one acute hospital, there have been some challenges about the culture within that hospital on some of their wards. Something that we're going to be taking up through our interview service. And access to services, again, that's about getting referrals, waiting for assessments. And there is a big issue about transport for some people. There are good health and care facilities, but people just can't get there. So that is something that needs to be addressed within the long-term plan. And I have said to the board that any long-term plan that does not refer to transport is not complete. Because if people can't get to facilities, they may as well not exist. Mental health is a constant theme. It's not the major one, but it's a constant one. And in particular, the role of the crisis team. And GP services, getting an appointment is one thing. And there's a shortage of appointments, and I think there is an issue about the number of GPs that are available. And the one that runs throughout all of these is one, and if anybody can crack this particular problem, they will probably get a knighthood, and that is parking. If anybody can crack parking, we'd love to hear about it. Has anybody been to UHCW recently and tried to park there?
Not an issue.
Every day.
You've never had an issue?
Not since they put the ANPR stuff in, no.
Really?
Yeah. It's really easy to get in and out for me.
No, it's not.
It is for me.
I went this morning, 9:20.
Yeah.
Not a space.
Because I had to turn around because I couldn't get in. I had to turn around and not go to a meeting because I just couldn't get in.
Since it's
Well, in
since
that case, I'm going with you next time.
Yeah, I'll give you a lift.
So the key concerns that patients are expressing to us about the 4 areas that I've talked about are communication. And what they're referring to when they talk about communication is the use of jargon, the use of acronyms, and not getting communication at the appropriate moment. One of my favourite bugbears at the moment are when you go in for a series of tests and they say to you, if you don't hear from us, it's all right. But they don't tell you after which point it's all right. And so you're thinking, is it 3 weeks? Is it 4 weeks? Is it 5 weeks? So we have tried to put in a protocol which says that we will talk to you within a fortnight to tell you what your results are. So I think that's only fair on patients. So communication is a really important one. We'd like to see the clarity about decisions being based on need. What we are concerned about at the moment is that what they're trying to do is to fit patients into the services that are available rather than designing services around the patient and the needs of the patient. So we are in discussion about that, and I think it's going to be quite a long-term discussion, I think. Hearing from seldom heard groups, we've got a particular project going at the moment working with homeless people. And they are one of the groups that have traditionally found it difficult to access GP services. And I think that position is now being transformed by the programme, because we are now talking to GP services about how you talk to homeless people. And that is beginning to, I think, touch wood, have a bit of an impact. Patient and public involvement, I was saying at our annual conference this morning, is at best patchy. There are some excellent examples of patient and public involvement and some pretty poor ones. And I think Leicester Road Surgery is an example of a pretty poor one. But there are some excellent ones as well around the place. So it's about evening it out so that all patients have the opportunity to have their voices heard. And the final one final two I quickly wanted to talk about was instability in social care. And that's the loss of care home beds and the churn, the turnover of care staff. We're talking to some providers who are talking about turnover in the region of 20 to 30% of their staff in a year. And that is a huge turnover of staff. and it makes it very difficult then to ensure quality and continuity of care. So I think that is an issue, and it's something that integrated care as a system needs to address. We have had a number of care home beds closed of late, and that is something again that we do need to address. So those are the key issues, Chair, that we found as we've gone about. It's some of the key changes that are happening. I thought I would bring it here so that people are aware these things are going on. And I'm happy to take back any messages as part of those consultations that this committee would care to let me know.
Thank you very much. We have one speaker on this item, Mrs. Concord.
Thank you. You covered an awful lot there, Chris. I mean, it was interesting actually that you say your key concern is communication, because this consultation on the long-term plan, I mean, I go to quite a few meetings, you know, at the hospital and CCG and things, and it's all passed me by. So they're not communicating out. I mean, it's such an important thing. I don't know how you get around this. I mean, I did know about the stroke services one, and I have seen stuff in the local press about that as well. One thing I want to point out, in the paperwork there is the Health Watch report.
Yeah.
Things. And I mentioned the project with the homeless and things. Is that going to be rolled out sort of in North Warwickshire and things? Because it only seemed to be, you say Warwick district and then you've done Stratford. Is it going to come here? Because it sounds like a pretty good...
It's going to go to all 5 districts in the county. We would do all 5 at once if we had the capacity. But we've got one part-time worker doing it, which kind of limits it a bit.
Yeah.
It started off in Stratford. What we did was to take advice from the neighbourhood teams at the county council to say where is the problem most acute, and we then agreed an order in which we do them. Now, officially, according to the statistics that we were given by those neighbourhood teams, the worst was in Warwick and Leamington. Then it was Stratford. Then it was Rugby. Then it was Nuneaton and Bedworth. And North Warwickshire, they'll be happy to have absolutely no homelessness at all, according to the neighbourhood teams. We frankly don't believe that, because I used to live there and I know there is. So we're going to take the project there anyway, to talk to GP practices in North Warwickshire, to talk to them about the healthcare needs of people who are either sleeping rough, sofa surfing, or some other form of homelessness. Because I mean, there's one source of homelessness which is, I think, not being addressed properly, which is domestic abuse and domestic violence. It's causing some homelessness. And I think that you then look at the care needs of that individual who's made homeless for that reason, and they are more acute, and they have to be dealt with by a range of services. So we're determined to get access to those services through the GPs, but we can only do that with the GPs. So we're going to roll it out. The answer, that was a long-winded answer to say yes, really, wasn't it?
Yeah, I mean, I think I'll wait to see what the discussion is, because there are so many things. You know, you're obviously aware of what all the issues are. It's how you solve them is, you know, the bit that no one seems to have the answers to.
Any member? Councillor Hancock?
Yeah, Chair, thanks. First of all, Chair, through you, I think we ought to thank Mr Bain for his presentation. It's really informative, as it always is. It also raises the question on what involvement we have as elected members in getting involved with it. Public health things are meant to be cascading down to a more local level now. But call me old-fashioned, is in the old days of things like the Community Health Council, we always had members sitting on that, and before that, the old Health Authority things, there was always elected councillors on that. And so we don't quite have all that contact now, you know. I mean, Health Watch followed on from the CHC, and it does a fantastic job, but it's a totally different setup. I wanted to start off because within the document it jumped out at me on page 4 of the document, which is in our agenda. The first picture there and the line underneath says improved access to GP services. And Chris knows because I've been in touch with him about it. There's real concern in Bedworth at the moment about the Leicester Road surgery because it's being proposed to close. I'm not sure when it's February, it's fairly early in next year anyway. But I'm not aware of any consultation with us as local members or with the council, and I don't know whether there's been any consultation with Health Watch. You know, the clinical commissioning group, they should be doing that. They should be consulting not just with the users of that, but the people around it as well, and those people that represent them. Because from my way of thinking, okay, it's a fairly small surgery, and the latest thing I've seen was that some would perhaps go to the coal house practice in Park Road, but actually the Bedworth Health Centre is probably easier to get to for them. But already, I can't speak for the Park Road practice, but certainly at Bedworth Health Centre, you wait a considerable time to get an appointment to see a GP, and I don't see how closing one practice isn't going to make that worse, whether it be at Bedworth Health Centre, Park Road, or anywhere else. So I'm really concerned about that. Chris also mentioned about the acronym again, JSNA, Joint Strategic Needs Assessment, and there's probably people in this room who are more knowledgeable on it than me. But certainly the involvement I've had with it has really highlighted certain areas, mainly the ones that we kind of know about, our areas of deprivation and things such as B and Abbey and places like that. But there's a lot of good information in that, providing it doesn't just sit within a document, but people take stuff on board and are able to do something with it. And maybe this authority needs to push that along. Chris also raised one of my old bugbears, and that's about transport. If you live in Bedworth and Nuneaton and you've got somebody that's in Walsgrave, I'll call it Walsgrave because that's what people call it, it's really difficult to get to. From Bedworth, you've got to get a bus into Coventry and back out, or there is a loop one now, but it goes all round the Wrekin and that. And I've always had the view that if you're actually a patient, you're probably not bothered where you are, because you're getting that treatment that you need. But to get better, you need that support of your family and other people. They need to be able to get there. Those visitors are absolutely essential to that recovery period, which takes us on to the car parking thing. Oh, I couldn't believe when Councillor Gold said she never has a problem. She must come at the right time, because certainly it is. Not long ago, when I was taking somebody down there for an appointment, I got a £60 fine for it. And if you look on various social media and things, there's loads of people being caught out on that. And, at a time that's stressful enough, without having all that on top of you as well, it's really difficult. In my particular circumstances, there was a chap in front of me. I must have waited, I don't want to exaggerate, I'll say 5 minutes, I think it was longer. He couldn't pay. He wanted to pay, he couldn't pay. In the end, he gave up, so I assume he was another one that got a ticket. I tried to pay, couldn't pay, so left, ended up with a letter about a week later with a 60 quid fine. You just don't need it. And in regards to the George Eliot, it's equally as bad. Once you get into that, I was visiting somebody a couple of weeks ago, and on 2 days, and I am accurate with this because I've deliberately clocked it, it was 25 minutes with me driving around the car park before I got a space on the first day, and it was 35 minutes on the second day. Yes, there's too many cars on the roads, I suppose, but it's it. Anyway, something probably more serious. I'd be interested to know if, what Chris knows about it. Is a long concern that I've had is with the shortage, particularly of dementia beds in Nuneaton and Bedworth. And you know, I'm aware of people that have had to go to care homes right down the A5 because there aren't enough in the Bedworth and Nuneaton area. And you know, there seems to be, again, with the ageing population, that is an increasing condition that's there. But I'm sorry there's so many things, Chair, and they're probably mostly statements, but if Chris can perhaps answer something about the dementia and anything else.
Yeah, the provision of dementia beds is an issue that we've been raising now for about 5 years. And I think one of the challenges is that demand is actually quite hard to calculate precisely. And in terms of care homes that specialise in dementia, it is becoming harder and harder to locate beds in those care homes who will take people. Because they will then have to primarily redesignate themselves as nursing homes rather than residential if they're going to take on complex needs. And I think that carries with it certain responsibilities if you're a nursing home. So I think it isn't something that's going to be resolved easily. I think what they're going to try and do now is, I think if we can get earlier diagnosis, and that would be part of the response, because it is interesting that when they incentivised diagnosis a few years ago as an experiment, we suddenly found a lot more people with dementia, because GPs were receiving a payment for finding it. So I think if we can get to a point where diagnosis of dementia is better earlier, then ways in which you can manage that condition will be better as well, because the quicker you can actually get onto that, the better. But what it won't do is resolve ultimately what the supply of beds is. And the only way that is going to happen is if you have the trained staff, if you have the resources, and if you have the will to do it. Because what it does is compete with other priorities. That's what it's got. And if you have a choice, and let's be honest here, if you have a choice between beds for cancer patients and beds for dementia patients, by and large, the cancer beds win out because you can see the results. So I think in the long term, we are going to have to make a decision as a society that one of the prices we pay for living longer with long-term conditions is that we have to put in the services that accommodate those. Because I don't think dementia is going away. I can't see a cure anytime soon. So what you need to look at is the way in which you can manage those conditions. And inpatient beds are amongst the solutions to that. But even then, you still have the trained staff to be able to deal with it. Because there are things like, for example, at A&E staff, people in accident and emergency units trying to deal with people with mental illness or dementia is a particular challenge. It's a particular challenge. And amongst the people who are best at dealing with it at the moment are the police, who are really good at it. And when you talk to people who've had experience, the police come out best of all the services that they deal with. So it is possible to get a receptive service in that way. But what we're going to have to try and do is to work collaboratively, and I hope the integrated care system will be a part of doing that, in which health and social care and the third sector and all of us work together to make sure that we have places where people with dementia can feel included and can feel safe.
And can I just ask Chris to go back to the issue over consultation or lack of consultation? I mean, I raised it on the back of the Leicester Road surgery in Bedworth, but I believe it's a problem really over a lot of issues.
We had a particular argument with NHS England about the Brownsover surgery in Rugby, which was closed in similar circumstances. And what happened there was the patients turned up and there was a note on the door to say that we're not carrying on. And that was, I believe, a similar similar situation where the practice had said that we're packing it in, we're going to give up our contract. And that presents a real challenge, because what you then have to say is anybody else willing to take it on? But what NHS England should be doing is talking to people who are in that area and saying, this is the problem we've got. What's the solution? Would you be prepared to travel to another surgery? Would you be prepared to wait while we put another one in place? They're building a new medical centre in Brandsover now, and it's a really good one. I've been there and seen it. But that took us 2 years to get NHS England to move to that position. And we did put pressure on them, including me refusing to leave the regional director's office until I got an answer. I was bursting for the loo as well. But I refused to leave the office until I got an answer, and I think what we will do, Councillor Hancock's, is to take this back, to get on to NHS England and say, why is this closing? And what are your proposals for an alternative? And I'm very happy then to share what we get back from NHS England, because they might reply to us.
Okay, thank you.
They don't always reply to everybody, unfortunately.
Councillor Gold.
Thank you very much. You might want to speak to Margaret Bell actually about that,
Yeah.
because she brought some information to the county.
About that surgery.
About, yeah, it's the recontracting. Nobody wants to take the contract. So,
I thought it might.
Yeah, it's the statutory obligation to recontract, and nobody wants to take the contract on.
Yeah.
So that is the position, but she's actually dealing with a few things on that, so you might want to have a word.
I'll get in touch.
Yeah. The transport, I've actually suggested a shuttle bus runs from the Elliot to UHCW. I've suggested that quite a few times at the County Council. I'm hoping somebody at some point will actually listen and put it on as a viable option, because I think you would get staff using it, I think you would get visitors using it, and I think you would get patients using it. And if you charged a nominal fee and it was a point to point, you would probably actually make some money on it as well. So I'm with you on the transportation aspect. With regards to what level of consultation involvement we have, we at the county, again, because Chris is involved, we have the health overview and scrutiny committees for which members of the cabinet are invited from Nuneaton and Bedworth, and unfortunately they very rarely come. It is unfortunate, but they are included in the group that can attend. The CCGs are there. We question third sector providers. I mean, we've got all sorts going on. So there is a way for people from Nuneaton and Bedworth to actually attend at the county, and again, Chris and I are on the scrutiny committee, and we have a joint overview and scrutiny committee with Coventry City Council, which we had one of those earlier on this week, and that was to discuss, because quite a lot of stuff anyway is cross-boundary. So we have a joint overview and scrutiny committee, and Councillor Phillips, Neil Phillips, was there, but he didn't attend the full meeting. So, they are invited, members of the cabinet are invited, so whether they turn up or not is another question. The homeless card works brilliantly. I've dealt with a couple of people in Nuneaton and Bedworth. I know it's not been rolled out in Nuneaton and Bedworth, but the cards that you brought to county, I've actually given a few of them out, and I've had a response back off one particular lady who was getting nowhere with medical services until she got the information. So thank you very much, it works a treat. And yeah, the sooner we can roll it out, and I'm sure there's plenty of people, especially now we're coming into the winter night shelter time, Salvation Army, they would be more than happy, I'm sure, to be a distribution point for things like that. But yeah, it does work. And I think sometimes, genuinely, it's not out of any sort of malice that homeless people are being turned away. I think it's because genuinely the staff at the surgeries aren't quite aware of where the legislation stands or what support they do have to provide. So it's not a negative thing from from a particular surgery, or, I mean, it might be, but in general, I don't think people are out and out that obstructive to stop somebody getting medical treatment. I think it's just a misunderstanding of what the NHS does have to provide for people. So to get the message out there that if you are homeless, you are still entitled to be treated at a doctor's surgery. That is only going to be a positive, I think. But yeah, so the quicker we can get that rolled out locally, the better, I think. And stroke services, yeah, respond to the stroke services consultation. Definitely. There's a lot of information that was presented at County on earlier on in the week, and it is highly led by clinicians, which is something that I pointed out as being a positive. Is it's not a tick box exercise. The people that were in the room the other day are literally the people that would save your life if you had a stroke, and they are the people that have designed this service. And I know that there's a bit of an issue with the fact that everybody's going to UHCW in the first instance, but they are aiming to get a faster turnaround of people coming out of UHCW and getting them back into a home situation or getting them into a rehabilitation situation. So I know the transport will be difficult, and when you've got somebody that's in a dire situation and all you want to do is get to them and maybe you can't actually get to them, it's not a nice position to be in. But when you offset that with the fact that if that person goes to somewhere that you can get to, their risk of death is higher, it kind of balances it a little bit. I would rather have somebody go and be treated in a facility that has a higher probability of them actually surviving and me not being able to get to them straight away than me being at a bedside and having a fatality. So, you know, it's not necessarily, again, it's not necessarily a negative thing. And yes, when you look at the stroke services realignment, there is going to be a loss of beds. However, that loss of beds equates to services actually in people's homes, so it's not a loss of service. So again, we've got to be careful with the language that we use. But yeah, definitely read up on the stroke services and get involved, because I think it's incumbent on us all to do something like that and to provide responses, because that's what we're here for. We're here to represent people that are going to be using those services. So, yeah.
Thank you. Councillor Llewellyn-Nash?
Yeah, Claire's brought a few things up quite nicely for me to sort of carry on. I can remember 15, 20 years ago, the George Eliot used to be first almost in stroke services and coronary care services, and I think Claire was ordaining to the thrombolytic drug that if you have that within I think it's half an hour window or an hour window, then you're pretty not safe, but you're going to have your percentage of survival is going to be increased quite some time. And what concerns me is that the Elliot having really good stroke services, because I used to work in the Elliot at that time, and I know I knew the manager of the coronary care services, and he used to have patients say to him, please don't take me to UHCW, I want to go to the Elliot, because they had a really good team. And it's quite sad to see that both of these departments have demised over the last 15, 20 years. And surely, you know, having, as Claire said, you know, having really good local services, especially for people from Nuneaton and Bedworth, being treated at their local hospital, i.e. the George Eliot, is going to be far better than you know, even transferring them to UHCW, because you know what the M6 is like. If you're in an ambulance, even, you know, they get stuck. So I'm wondering why both of these services have taken not a down, but they're not as prominent as they used to be. My other, you brought up about dementia and early diagnosis, and there have been quite a few programmes, Panorama, BBC, etc. You know, do we need to start thinking outside the box and having alternative ways at treating dementia? And I'm thinking particularly the Scandinavian style of how they treat the dementia. You know, even not having them on a ward even, but in proper sort of flats and accommodation. I know there's one place, I think it's in Denmark, they've got a whole complex which is sort of 30 years behind its time, and it's had an amazing effect on the dementia patients, so that they're not confined to bed, which is how we find so many of our dementia places, which is totally the wrong place, but they need to be up and about, listening to music that they listened to 30, 40, so for us it would be punk rock, you know, and, you know, having shops set out as they used to be. So, you know, and I know this is all finance and money, but surely in the long term, sort of thinking like that is, and we need to start thinking about how can we do things differently, you know. And my final point is, you know, we hear a lot about GP surgeries closing. Now, why is that? Is that because the students coming forward, they see what GP surgeries are like now, and they run a mile? There's no way I'm going to be a GP with all the sort of things that it contains and stuff, but in not dealing with that problem, in not sorting the GP surgeries out, we are then putting this whole massive strain on the A&E department at the local hospital. So it's having a sort of a knock-on effect. So you've got A&E, which is under strain, and if you, I suppose, took a percentage of how many people have gone to that department simply because they couldn't get into their GP surgeries. So this is an issue that really needs looking at. For myself personally, last week, it took me all day just to get in contact with my health centre, which is in Bedworth. But when I did, and I don't know if anybody else here, but particularly if you work full time, it's nearby impossible to get a GP appointment. However, I think Bedworth are thinking a little bit, because I managed to get one at 7:10 in the morning if I was happy to go there, which really, really helped me. But I think, you know, GPs aren't going to get less and less. In fact, they're going to get more and more. And so, again, is it, we need to really see why GPs don't want to continue working, don't want to sign their new contracts, and where are the future GPs coming from, if they're coming from anywhere.
Councillor Longdon?
Thank you. Quite a few points, but I think first consideration we will do is take on board what Chris said and schedule another meeting within 2 weeks to look at this long-term plan, put our point of view across. So we don't do that, we don't get a say as a council. So I think that's one of the things we need to look at. So that really needs priority. No, not everybody's going to like that, but that's the situation as it stands, and that's the advice we get from the health watch. So we've got to do something. If we don't, it's our fault. So if people don't accept that, that's fine. Right. Hello, Chris. Only our names haven't changed. There's a situation. Stroke services, what a joke. What an absolute joke. This decision was taken over 2 years ago. It's going. Doesn't matter what anybody says, it's going. And that's it. And the likelihood is the net loss of beds will be 31. That's what the predictions are. Wherever you go, whatever research you do, that's the number. And that's significant. That's about 50% of the beds will be going out. there's big arguments going on that they only used the transportation times model across London. There's been no, despite numerous requests to do it, there's no studies undertaken in Coventry and Warwickshire for that. The golden hour could be 3 or 4 hours. The result of that could be that somebody having a stroke or had a stroke will get there a little bit too late to either 2 options, or they die or become severely disabled. And that means that they're going to cost the health service far more money in rehabilitation and to look after, basically. So it's a false thing. I'll respond again. But over the years, it's been there, it's going to happen, and it doesn't matter what anybody says. It's a complete and utter waste of time, and that's what's going to happen with the stroke services. Nice to think that somebody might actually take notice of what's being said, particularly in terms of the transportation times. None of the transportation times, I hate to disappoint Councillor Golby, but Margaret Bell suggested a shuttle bus about 12, maybe more years ago, when we had the PCT even. She came forward with that idea, and that wasn't listened to then. It's come up at different times when different things have been happening. But yeah, it's not a new idea, it's just not been taken up, mainly because CGG don't want to take it up. Because nobody wants to pay for it, the hospitals don't want to pay for it, the CCG don't want to pay for it. So it won't, until somebody has a change of heart, it won't happen. Unless some enterprising person comes along and puts a bus on. I'm too old to do that now. I'm one of these old farts that are dragging down services and costing a fortune to keep alive. They're great ones to think alike, actually, because I picked up in your document the NHS long-term plan. I thought, ooh, I haven't heard about this. And then it says invest in an extra £20 billion a year in the NHS. Well, I can't find any record of that statement. I can't find out when it starts, when they're going to start investing this money. And there doesn't seem to be any other information about how it's going to be done. And then it went further down, it explains why. Because it's just open-ended, because it says will evolve based on the findings of the NHS long-term plan survey. So I'm not very good with new technology, but I put that in, I couldn't find a thing online. So if you reckon it's there somewhere, I don't know, I've messed up, so I have to have another look. I'll get my granddaughter to look for me, that might be better. But the issues on all of this, I mean, I don't know what it means about government is now investing an extra 20 billion a year, because over the past 9 years, in excess, well, the numbers I've found out, in excess of 300 billion has been taken out of the NHS. So it's less than a fifth is going back in, but it doesn't say for how long and what it's going to be spent on. And my experience over the last 7-8 months has been dire. It's been absolutely awful. And that's not so much at GEH, but certainly at UHCW. And we've got high-paid consultants who can't find out what's wrong with them. Apparently they've got something that's unknown to British medical science at the moment. And I'm feeling in a bit of pain now, so I might have to go a bit earlier today. I'll try to stop for the meeting, but we'll have to pop a few pills. But the issues, Chris, that you're raising, very serious ones, and we do need to take that seriously, and we do need to look at all these things that Chris is recommending, and we think we need another meeting to actually do that and put our slant on it in order to get something back. Because he's right, if we don't, NHS England won't know, and so well, you have the opportunity, and that's what NHS England do, very frequently, and sometimes even after the event, I've noticed they've done that, and I'm quite concerned about Andy Hardy and Glenn Burley getting their heads together, as he claimed not to do. I'm supposed not to like each other, but I don't believe that. Because they've both got an intention to deal with the deficit first before they'll deal with patients. You know, the deficit, you can argue, was because there wasn't enough funding in the first place and people still need to be treated. And then, of course, you have to pay that back before you start treating people again. So the whole thing was a collapsing circle on funding for patient care. And those two men are earmarked as public enemies number one for the health services in Bedworth and North Warwickshire, because you mentioned again the age-old thing about maternity and paediatrics. Mr. De Boer is probably stamping his feet again and trying to get his empire built even more than what he's got already. So I think we're going to get another attack on George Elliott Maternity, although each one's a failed so far. I think there were 4 attempts since he accused the Tribune to take it away, and each one's failed because UHCW just can't cope. They haven't got the capacity. Neither have got the capacity for the stroke people, by the way, at the moment. And that point was made specifically by Andrea Green when I raised it with her. And she said she confirmed that they didn't have the capacity. And I don't think they've got the capacity now because nothing's changed. And it's recognised at that level what on earth is going on. So the whole issue for me, we need to sit down and really go through this long-term plan. But how long is long-term? Do you know how long long-term is supposed to be? Because I'm going to be dead by the end of the work.
Because it started out as a 10-year plan, then it became a 5-year plan, then it became a long-term plan. So it's slightly imprecise in that respect. But I think the common thinking is it's 5 years about that. And the spend, the annual increase in spend that you referred to was announced by the Chancellor of the Exchequer and confirmed by Simon Stevens. And it's a 5-year programme of investment in the NHS.
Didn't see that.
And it's worth saying that the long-term plan, as it's currently constituted, is predicated upon us getting that income, and you cannot have the long-term plan without it. So I think it's fairly clear that NHS England are serious about giving it. And I've heard Simon Stevens talk about it, who's the Chief Executive of NHS England, and he's talked about it. So I think the commitment is there from NHS England.
I thought you might have got one.
Yeah, well, back to America, yeah. But the primary areas of investment that NHS England are talking about is in general practice, in primary care, and in mental health services, not in acutes. So that was the focus that they gave. I don't think it's changed, has it, Helen, in my time? No, I think it's still that. So it's about general practice and primary care, it's about mental health services, and it's about community services. Because what they want is to take the pressure off the acutes. And they can't do that by simply spending more money on the acutes. They have to work on other things.
Yeah, that rings a bell. Have you been consulted, or have you been told that neuropathy is now under the management of UHCW? Your neuropathy at George Elliott is now under the management of UHCW. The 2 secretaries gone, the 2 neuro consultants are still there at the moment, but it's not a question of if, it's a question of when the whole thing disappears and we have to travel to Coventry for the neuro things, and it's just going away piecemeal at the moment. George Elliott, it's horrific, and again that's Mr. Hardy and Mr. Burley. I'd like to get in a room with them too, and it's never going to happen in these days, but I'd really love to get in a room with them too and ask some searching questions.
And sell tickets.
it's I don't know if you knew that, but that's what's happened. That's what happened. Because I spent a day looking for the consultant at UHCW when I found out he was actually at GEH. But the letter said UHCW, and UHCW never heard of it. But then I found out, and then we had the information come through, and the Secretary of certainly got their UHCW email address. So they'll be making decisions on who sees who, when and where. Oh, they did actually for a while stick to the agreement after the acute service review, whereby there was visiting neuro consultants from the HCW. 3 of them were coming over, which was agreed because it was easier to get the consultants to patients rather than patients to consultants. So that idea didn't receive favour. So they didn't like it. So, but that's the only time I know that it happened. I mean, I found out because of what's going on with me, but that's by the by. But at least we made a note of it.
I think it's worth looking at the CQC's state of care report, because that does talk a lot about neurological services. It relates particularly in those instances to learning disability and autism, but I think it's across the spectrum. I mean, I gave a speech to the Dystonia UK a couple of weeks back, and they were talking about neurological services and general practice and how you actually can't get an early diagnosis because general practice is not sufficiently familiar. So I think there are all sorts of issues about those things. I think the trend is towards the centralisation of them.
Also, you know the process. There is no electronic communication between UHCW, GEH, and GPs. If you have a consultant, if you have a consultant appointment, the consultant writes a report. That report is typed, then has to be checked by him, signed by him, put in an envelope and posted either to GEH or your GP. And that can take an extra week to get that actually done. And I question that. Why can't you send an email with an attachment? No, not allowed. I don't know who is not allowing it, but somebody's not allowing it, and it's a nonsense. And it's back the other way as well. It's not just UHCW to GH, it's GH back to UHCW.
Thank you, Councillor. We've got 2 more members on the list to speak. We've got Councillor Brown and then Councillor Sargent. Councillor Brown.
Thank you, Chair. I'll keep this quite brief in the interest of moving on before we all need end-of-life care. Right, on the stroke services thing here, I just want to reiterate everything that Councillor Golby said. If this is clinician-led, then we're giving care in the way that the clinicians feel is the best way to do so. And there isn't a loss of service because people prefer to be treated at home. That is known and recognised. And it allows resources to be diverted to other places where they can be better used. So on the subject of trying to get an appointment at Bedworth Health Centre, register online, go online, get an appointment. It takes 5 minutes, get an appointment for 2 or 3 days. No problem ever. Thank you.
Thank you. Councillor Sargent.
I have a daughter who works in the NHS, does a fantastic job. And she works in the A&E department. And what they were saying is that education is needed to be given more to the public of what actually the A&E department is for. And they cannot turn anybody away, although rocking up wanting Calpol from A&E is a regular occurrence. So on your first page where you've got prevention, education and sporting, that's supporting the person who wants that where to go. But we've also got to support the people that are on the ground dealing with stroke patients arriving, car accidents arriving, then also dealing with large families turning up who want Calpol for 4 children. So, you know, where does that come in the education of everything that everybody wants us to do? because, you know, that is a dredge on the NHS, and also on doctors' surgeries, because they turn up at doctors' surgery wanting Calpol or an aspirin. So education has got to start from somewhere. And I think the NHS department is wonderful. I've been abroad and was extremely ill, and I tell you, I wish I was at home. So, you know, it's very well, lots of people knocking it, but there's a lot about the NHS that's right. There's not a big pot of money anywhere for anybody to spend in any department at all. Where's that going to come from? It's not, you know, you can't get it out of the sky. But if we can look at the areas that are overloaded because of bad usage, then actually that money then can be used better by the people being there to work with those people on a better... And I don't know whether that's the NHS to do or somebody else to do, but that is definitely a big thing. And she said it's draining, it's just continuously draining every day, all day. You know, they're turning up because they don't want to pay for Calpol. You know, it's that sort of stuff, silly stuff. Not silly to them, well, I don't want to upset anybody, but the reality is that, you know, a doctor's surgery and the A&E department is not where you go if you've got a headache.
Not quite. No, I think people should be treated where it is best for them to be treated. And the part of the rationale behind opening what are now being called urgent treatment centres is where somebody is probably slightly too poorly to wait for a GP appointment, but nowhere near poorly enough to go to A&E.
Yeah.
And the urgent treatment centre is designed to deal with that. They still should get their own bloody Calpol, let me just say.
Yeah.
I don't know what
You
that
can get it for free.
But that happened. I mean, she works at Birmingham's A&E Children's Department, so it's just endless. You know, but I think the education side is, you know, we need to different areas coming together to make sure that we're all educated on all different departments.
I think that's right, because we've had people ringing 999 asking for cooking recipes because they couldn't find it anywhere else. So they rang 999. And I talked to people who deal with these things in call centres, and some of the requests they get are ludicrous. And so it is, you're right, it's about educating people to say, if you're misusing the service, you're denying it to somebody else.
Absolutely.
And you cannot continue doing that. And we all have a responsibility to make sure that that's done properly.
Or be turned away. And I know that's really difficult, but the reality is if you turn up with a cold, then you should be turned away. But they can't turn them away, and that's, you know, where does that start?
That's part of the NHS constitution, unfortunately, is that they have to treat them.
Yeah.
It's like our project with homeless people. People are entitled to what's called immediate and necessary treatment, regardless of whether they have an address or not.
Mm-hmm.
That's what the Constitution says, and that's what our project is about. I think it's really important. But people should go where they need to be. You should only be in hospital if that's the only place for you to be. You shouldn't be there any other time. And going back to stroke services, I think it's worth saying that UHCW will bring together some of the best specialists and the best equipment. And if I was to have a stroke, that's where I'd want to go at the moment. Even if it took slightly longer to get there, I would still want to go there. Because I think they're getting the best people there. So the part of the long-term plan thinking is to invest in primary care, in community services, mental health services out there in the community, so that you only go to hospital when you need to go there. But when you do go there, you should get specialist services and the best services. And to me, that actually makes sense. That actually makes some sort of sense. Because what you can't have is that kind of highly specialised service in every district general hospital. You just can't afford to do that. So at some point you have to make decisions about where really expensive people and really expensive equipment are gathered. And at the moment that's in tertiary centres like UHCW.
Okay, thank you very much for everybody's contributions, and thank you very much for your presentation this evening. Thank you. So moving on to agenda item 7, health and wellbeing annual report. So this is going to be presented by Helen King. Thank you.
I can't sit here. Thank you very much for the invitation invitation to come this evening. I'm sorry I was a bit late, whereas others haven't been able to find car parking in various hospital car parks. I found lots of it on the A46, the M6 and the A444, but I got here eventually, so thank you very much. My name is Helen King. You have me down, I think, as the Interim Director of Public Health. Well, I'm now back to where I was as Deputy Director of Public Health. Our new director has just recently, 1 week ago, taken up her post. My purpose for being here this evening was to give you an update on the Health and Wellbeing Board, and particularly the annual review from 1819, and also the development and delivery plan that's being spun out from that for 1920. Well, I wondered if I can beg your indulgence, because I'd like to use that as a platform also to talk a bit about some of the other developments that have been mentioned this evening, in particular things like the Joint Strategic Needs Assessment and our place-based work. So if I can weave that all together and give you a presentation that will cover all those areas. Yes. Okay. So just thinking through the Health and Wellbeing Board annual review initially, and I'll pick up the various elements of this during the course of the presentation. But the annual review allows us to reflect on the achievements in health and wellbeing across the county. It's a review that brings together a number of the duties of that board, including examining where we've got to progress with the strategic needs assessments, what's been produced. We bring the pharmaceutical needs assessment to that particular board, and we also use it as a means, because it's a partnership board, to endorse commissioning intentions from both NHS and from local authorities as well. We get regular reports given around the Better Care Fund, which is where we look at currently sort of integrated working around health and social care, and also to bring together the developments for the Coventry and Warwickshire Health and Care Partnership, what was previously the SDP, or Sustainable Transformation Partnership. I'm afraid I still use SDP, it's slightly less of a mouthful. We bring together information around the development programme, particularly the Place Forum with Coventry. That's where the two health and wellbeing boards meet and look at the developments that they can add value to together across our patch. And all of that information is brought together in the report, which is available online. One of the things that we also deliver at the Health and Wellbeing Board is the Director of Public Health's annual report. This is an independent report of the Director of Public Health. It's produced annually, and it's the local authority's responsibility for ensuring it is published. And you will find we've just taken charge of about 1,000 copies, as well as being online. We have hard copy, and you will all be receiving a copy. In the meantime, it is available online. And this year, the theme for the report was around the impact of work on health and wellbeing of the working age population. Nationally, we've had a really big drive to improve wellbeing in the workplace. It's important in terms not only of, it makes sense in terms of productivity, but also addresses particularly the mental wellbeing of staff. And we've highlighted within the report a number of the key strategies and policies that we have locally as well as nationally. And we chose the theme because we felt that the potential for further health gain and well-being in this population group is particularly important. If you consider that between all the public sector organisations, we employ many thousands of people, think of the impact that we can make through the policies and support that we can give through our respective organisations. So in addition to picking out those themes, and I'll talk a bit more about the recommendations in a moment, the report also provides an update on the health and wellbeing of the county, and we look at that both in district and borough, as well as county level data, and also by clinical commissioning group. So you'll find material that's relevant for Nuneaton and Bedworth throughout that report, and it shows you particularly the variations. At Warwickshire level, we probably have we're doing fairly well compared with the rest of the country. And we have had quite a number of improvements. Our life expectancy at birth is certainly better for females, and it's similar for males. Other things that we have achieved, we've brought down some of our cancer mortality rates. Percentage of people who are in employment has increased over the past 12 months. We've had steady decline in the under 18 conception rate, and that's been a lot of hard work from everybody at all levels of local authority to secure that. And we also have improved the percentage of young people who are not in employment, education or training. And I think we've halved that, and that's really important. And, why is this important in terms of health? It's what I would call the wider determinants of health, because the more education you have, the better your work opportunities will be, the more impact it has on you living a longer and healthier life. However, we can go on to the next one, thanks. I think there is more work to be done, particularly around obesity, alcohol consumption, mental health, suicide and smoking. I am particularly concerned around the fact that we have really high levels of under 18s being admitted for alcohol-specific conditions, and our mortality rate around suicide is still high. So we have a lot of work to do. And again, when you look at this over the county, there will be variation, and I'll talk a bit more about that when we get to look at the JSNA. Thanks. Some of the recommendations we made with regards to improving and promoting working for wellbeing in the county. Some of it covers what we can do as a county council and in public sector, working with businesses to support health and well-being, seeing for businesses particularly recognising that it's a key element of their business to ensure that they have a healthy and productive workforce. You're more likely to get less sickness absence and more likely to remain and work. So the need to invest in that well-being, the case is made. We can, as I mentioned before, we can do a lot through supporting our own workforces in the public sector, and to influence then the wider circle around family, as well as improving our interaction with customers and parents. I'm happy to say that through the Year of Wellbeing, which is a big program that we have been promoting through the Place Forum, which brings together the two health and wellbeing boards, most of our public sectors have signed up to the Thrive at Work programme, and that's a framework which enables employers to support the health and well-being of their staff. It allows you to audit what's happening and then to think through how you might improve that, and everybody has signed up to that. And finally, what more we can do working with Department of Work and Pensions and other partners to ensure that we're all of us investing in work to support and improve the health and well-being of those out of work. And when you read through the report, whilst we might be doing pretty well in terms of our overall employment rates, and where the biggest gaps occur are for those who have any form of chronic mental health or long-term mental health condition, and also for those who have learning disabilities or physical disabilities. It's a really sharp gap there, and I think to me it points to where all of us as a partnership need to focus and see what more we can do. And there are already some extremely good programs that are run across the county to help support that. Thanks. I mentioned earlier, and we had a question around the place-based joint strategic needs assessments. I mean, these needs assessments, it's a statutory responsibility for us to undertake this with our partners. In the past, we've tended to look at thematic joint strategic needs assessments, so that we might look at maternity services, we might look at alcohol and drug, substance misuse, what are our local needs. But in 2017, we piloted a new approach to our JSNA, and Atherstone was the first area in which we worked, and that was successful. It enabled us to really focus much more on what the needs were of particular specific localities. So where we might look at something at a county basis, we wanted to focus far more on smaller geographic areas. And there were some 22 areas that we have looked at across the county. We're now just entering into the final phase of these particular joint strategic needs assessments, and they're helping us really to think about how we target our resources and actions more effectively. We should be finishing this process by the end of March 2020. The example we've given there, we might look nationally as if we're doing pretty well when it comes to issues around obesity for children in particular, because we height and weight measure children at reception and then again in year 6. And in that time, I'm afraid weight doubles. But if you drill down much further, you start to see what some of the massive variation is in different areas. Here we made a comparison between Kenilworth at reception, 4 to 5 years old, and Atherstone, where you can see the difference. And then when we looked at 6 and 11-year-olds, you can start to see the difference between, in this case, Covington and Bedworth Central. So it's a useful tool to help us think, well, when we have a limited amount of resource, where is it best for us to invest that to make the biggest difference? There are a number of common themes that have come out across the 2.5 phases of the Joint Strategic Needs Assessment so far. The ones that I pick out, I think, are transport and isolation, which we've mentioned earlier, young people and mental health are amongst a number of the themes that we've been looking at. If we then draw that up to, or add in all the 22 JSNAs by place, and we're now looking at the work that we do in terms of our integrated health and care programme, or partnership dividing us into north, south and central in Rugby. Some of the things that we have pulled out, particularly for Warwickshire North, which covers Nuneaton and Bedworth, are things like under 18 alcohol specific hospital admissions, which are the highest across the West Midlands. Nuneaton, Central and Polesworth, Atherstone and Hartsell, we've got an increased prevalence of diabetes, hypertension and obesity, so what might we want to be doing there as a partnership? In Nuneaton Central, it's the 4th highest of all the JSNAs for rates of admission of self-harm. Visitors to the Nuneaton Food Bank are up by about 10% in 17-18 from the previous year, and so on. So it gives us, it's a really rich source of information that can help us then to focus on what we might do as individual organisations, but also as place partnerships, and that some of our work going forward will be to bring together action plans at place level, which we need then to ensure that they're consulted upon and agreed. And I think that there have been all of the current JSNAs that have been pulled together have been done very much in partnership. Much of that information is being pulled together as part of the annual review of the Health and Wellbeing Board's strategy, and it will help in the development programme for both the board and executive members, and it also helps influence the key areas of work that we have been looking at in terms of the Joint Concordat and the Year of Wellbeing that we looked at in 2019. Just a quick picture here that one of the things that we have looked at as the PLACE Forum has been an agreement around the health and care system model for our 3 places. And this particular, it's based on a New Zealand model in fact, but it helps to show that how all partners are playing a role in health and well-being, and it very much puts people at the centre of our plans So our health, our place, and then around that, how we engage, the partnerships required in order to be able to deliver the place-based working and the system outcomes around effective services, strong communities and healthy people, which are the key themes of the health and wellbeing strategy. In terms of where we're going next, we have refreshed the strategy for 2018-20. The strategic priorities, I think, are still important. We just mentioned around independence, community resilience, and integrating and working together. And I think, Chris, you picked up quite a lot of that in your presentation. And we're also looking this year at a continued focus on prioritising prevention. We've seen that through the year of wellbeing, strengthening communities, coordinating services, and how we share responsibility for our health improvement. And in terms of what's next, we're, I guess, asking all board members and partners to champion the achievements that are laid out in the annual review. We'll be refreshing, in fact we're in the middle of refreshing the health and wellbeing strategy for 2020 to 2025. It will be informed by the JSNA findings. We're trying to make sure that it also aligns with the NHS 5-year plan, and because we're now part of the strategic transformation partnership with our colleagues and agencies in Coventry, we're trying to make sure that all the various plans line up, so that we get, I hope, much more impact in terms of what we're trying to achieve. And I hope very much that you'll feed your views into that shaping. There was a meeting which I think perhaps some of you will have attended last week, which was run for us by the King's Fund, which said, well, if we're, the framework that we have going forward needs to look at probably 4 major areas. We need to look at our communities, we need to look at our health and lifestyles, we need to look at how we do our integration for health and social care. The last one was completely gone from my mind. It'll come back during when somebody asks me a question about it. So I think if we can bring that together, we're likely to have probably a more effective and efficient strategy going forward. And again, it's very much, the emphasis on prevention. One of the things we can do if we want to reduce demand is, what can we do to stop people getting there in the first place. And just a last slide shows you all the partners involved, and you are all very much in the centre of what we're producing. Thank you, Chair.
Thank you very much. I believe we have one speaker, Mrs. Constable.
I don't particularly want to say much, but you'd be pleased to know. It's just really tying in, it comes up time and time again. We have all this information, things, we know who's in greatest need and what have you and things, but they seem to be the hardest people to actually get the message to. I've been to umpteen meetings over the years and things, how do we get to the people who need to hear it most?
Well, I think that it's in a number of ways, really. First of all, how do we listen? How do we really go to find those who are not normally represented? And how do we then bring that information back to work with them in co-producing effective programs and services? You see some of the things that we've certainly been looking at, for one piece of work around 0 to 5s in order to understand what the needs were for parents, carers and families. We have used an ethnographer who then went and generated 8 families who had, on nobody's particular register, nobody's had no particular contact with services, but had some really significant issues that needed to be tackled. And so we make the additional investment in order to be able to reach out and fine. So that is one way in which we can do it. We draw on the work of our colleagues in Healthwatch to help shape things in that way. And I think ensure that service users are constantly involved in how we shape those programmes. And not just saying, you know, we can tick a box and say we've asked a few questions, but you really go the extra mile to ensure that that involvement is there. And it's hard work and it takes a long time.
With the place stuff, I mean, that seems to be sort of working so that it, you know, get much better targeting. How does that actually work in terms of the pot of money? Are you able to put more into the things? Or do the other people say, oh, we want our share, and you know, it's not fair, and all that sort of
I think, well, there are two things that I think have really encouraged me around the place and the way the joint strategic needs assessments have been undertaken. It's been very much a partnership that has involved, in some instances, locally elected members who have either chaired you know, their particular locality or have had an involvement in it and who know their patch. And has, you know, encouraged others also to take part in that. The money will be the money, but I think what has come out of the JSNAs and the shaping then of the action plan is, well, with what we've got, where might we need to target it some more? What might be some of the, you know, the priority areas that we look at? And that will be different according to each of the places.
Thank you. Any member?
Mine's not a question, more of a proposal put forward. Obviously the annual report that we're going to receive after you've already spoken. So what would have been helpful is if we'd have received the annual report before you come and speak, because, you know, even if we've been given it tonight, to flick through a document like that, it doesn't give you justice or us. So if in the future, if we've got annual reports that are going to come, it would be helpful if we receive those before and then talk about it afterwards, so we've got something to look for. So it wasn't a question, more of a request.
Thank you. That's really very helpful.
Thank you. Councillor Hancock.
Yeah, thanks, Chair. I mentioned earlier on, it was actually during Chris's presentation, about the JSNA work, and it's highlighted a lot of different things. But the important thing is what we do with it. And the cynic in me says for 20 years or so, I've been listening to this phrase that has been commonly used about narrowing the gap in Warwickshire, when the truth is we all know in the north of the county there's much greater need than the south. I've seen parts of the things get even wider. There's been some improvement in some things, but a lot of things have become wider between the north and the south. And it really is about time, Chair, that the resources are put into the areas of need. And if the JSNA is pointing out these things, certainly in some of the areas and the JSNA meetings that I've been involved in, it highlights that. But the proof will be in the pudding, Chair. So I'm sorry if I sound cynical, but it's only because I've seen it all over the years repeating itself, and that finance hasn't shifted from the south to the north like it should do.
Thank you. Any other member? Councillor Long.
Much along the same lines, Chair. We don't appear too bad in focus area 3, but that's mainly on debt. CAB services, and little to do with anything like that. But area 4 is concentrated totally in the south, where there seems to be a lot more practical applications for people. So Bill's absolutely right. We are suffering in the north, and we always have the JSNA. We started up here, and we were promised all sorts of things, and I can remember. Getting too old, I can't remember. Yeah, I can't remember. 1993, being told that the areas of deprivation in the north of the county would be dealt with. 2019, not once an edge of difference at all. Have I noticed, especially amongst members in my ward, and it's it's never actually been tackled. The JSNA was going to be the thing, but it doesn't get to. There's all these meetings bringing people together, but it doesn't actually include the hard to reach people. And they're the ones that need the help. And that's where it's not, that's where it's failing. But as I say, on this paper anyway, Area 4 seems to be doing exceptionally well in the south of the county, Area 3 well. Because we all spent lots of borrowed money, we have to have debt counselling. Very good. Area 5 doesn't do as much good either, because most of the suicide prevention stuff was being done by us anyway. And it doesn't mention either anywhere that I saw when I read through this, ex-service people totally omitted from this, and yet they're some of the most problematic people. Not a mention, just what we've got an ECP to try and keep people out of the hole. So, sorry, not totally impressed. And when I used to go to Elton, maybe I used to get kicked out most of the time anyway. Required to leave, because it was never ever about up here, it was always about down there. And nothing's changed. There again, it won't be a problem next year. Either be retired or dead.
Any other member? No. In that case, I'd like to thank you very much for your time and thank you for your presentation. Thank you. Okay, moving on to agenda item 8, Child and Adolescent Mental Health Services CAMS. I'm going to hear a presentation by Louise Berta.
I have colleagues from CWPT with me. I think last time I came there were a number of questions that I wasn't able to answer, so my colleagues at the back are from CWPT. I'm Louise Berta. I'm the Commissioner for Children's Mental Health on behalf of Warwickshire County Council and the 3 CCGs. I've done a presentation kind of highlighting the areas of concern that I think were raised last time I was here a year ago. So hopefully I'll cover all the points, but I'm sure you'll ask me questions at the end as well. So as you're aware, the RISE service is a partnership between Coventry and Warwickshire Partnership Trust and Coventry and Warwickshire Mind. The general aims of the service, on to the next slide, and the new contract, I'm sure as you're all aware, was to have an increased emphasis on prevention and early intervention, to have a single seamless service with no tiers, which is within the NHS is quite a new thing, to have more integrated working, especially working closely with schools, and to support the whole family and the whole system, not just the child. And in that way to help children and young people bounce back when things get tough. Making it easy to get help and having the slogan "No door is the wrong door", and supporting children and young people 0 to 5 in a way that matters to them. And one of those is going the extra mile. 25, sorry, what did I say? 5, right. Sorry, 25. And going the extra mile to reach those children and young people. One of the things that was raised last time I was here was about access to the service. So I was trying to highlight the different ways, the different groups of accessing the RISE service. So for families, we have a revamped website, which has a resources section, a section particularly for parents, a section for professionals, leading you through different help pages as well, and advice. That is still in development. I think we've been developing some videos to go on there as well, so to make information more accessible to people as well. So it's not just written things, it's videos as well. They'll be coming online. The Dimensions tool, which I'm hoping you're all very familiar with. So that's not just for families, but that's for professionals as well. I've got a slide to give you more information about the Dimensions tool, but basically it's an online tool to help families and professionals with signposting, understanding what support is out there and what support they may be able to access. For families, there's also one-to-one consultation sessions and information sessions in the 5 community partnership venues throughout the county. For professionals, as I said, there's the website, but there's also the navigation hub that's got extended opening hours, so from 8 till 6, Monday to Friday. There's also the primary mental health team who provide training for professionals, but also consultation support either over the phone or you can go and see them. For children and young people, the service provides therapeutic support, but also in terms of early intervention and prevention, there's a lot of work going on in schools, both with the Big Umbrella programme, Voice of Mind, and the Boomerang programme, which is delivered by our primary mental health team. So some more information about the Dimensions tool. So this is developed by Coventry and Warwickshire Partnership Trust. I think it's fair to say there's been a lot of interest both regionally, nationally and internationally in the Dimensions tool. It's quite groundbreaking, I think, in terms of the information that it provides all in one place. It was co-produced with parents, carers and referrers and clinical staff. And users answer up to 28 questions on dimensions around health and well-being. It then creates a report that you can either use with the school or you can use when you're working with RISE as well. In Q1, I've tried to put some information kind of in terms of how these things are being used. So in Q1, the team attended 8 promotional events around the county to publicise the Dimensions tool, because I know that's something that the people, the professionals and families are really interested in knowing more about. So in terms of our community partnerships, we have 5 community hub partnerships. We've got the recently opened Abbey Centre in Nuneaton, as well as the existing venues in Stratford, Addiston, Rugby and Leamington. They're providing a mixture of coffee mornings for parents and carers around understanding and managing a variety of issues for children and young people. And in Q1, so that's April to June this year, 9 coffee mornings were held with 38 parents accessing that support. There are also parent one-to-one consultation slots available in all the 5 community partnerships. And in Q1, there were 56 consultations offered and 50 slots were taken up. As you can see, the largest take-up was in Nuneaton and Bedworth with 19 slots filled. And then I've included some information around the outcome of those consultations. So that you can see it's really specific on the needs of the people who are receiving the consultations. It's not one, here's some information, off you go. There's a variety of outcomes that come from those consultations. The next slide is around some more information about the variety of prevention and early intervention work that has been ongoing. So as I mentioned, the Big Umbrella, which is delivered in schools, so there are whole school assemblies, there are smaller resilience workshops, but there's also the option for one-to-one support for young people. We've got Relate one-to-one counselling. There's group work around for early intervention and prevention stuff around anxiety and low mood. We've also got the mental health in schools framework for children who are accessing early help support. And so there are a range of interventions there, from one-to-one counselling, bereavement support, those sorts of things to kind of get in there early to prevent issues escalating and requiring CAM support. And then there's the rollout of the School Age Incredible Years course. I think the service has said the Nuneaton and Bedworth course is delivered from the Abbey Centre and is already oversubscribed. We've also included a case study here provided by the service, which I think really illustrates the way the various different levels of support can come in to support families and young people at different times and in different places. So Bob and June are the grandparents of Sophia, who's placed in their care. She's 11 years old and has witnessed some distressing things at home, which is why she's with her grandparents. and she's been displaying some challenging behaviour and some anxiety symptoms at home and at school. And I think these are quite classic things that kind of come to rise, really. So the grandparents access support through the community offer, attended a one-to-one consultation with the primary health nurse, a mental health nurse, at the Radcliffe Centre in Atherstone. So following this consultation, a plan was put in place around the family to support Bob and June and to support Sophia. A number of areas. So Bob and June themselves attended the Incredible Years parenting course, and school delivered the Boomerang Resilience course, which they had been trained in, to provide that wraparound support within school. Sophia's behaviour and anxiety is improving, which Bob and June have agreed was the result of attending the early years course and the support that was provided in school. They've reported that they felt contained by the support, and they shared this at the peer review that was held at the beginning of the year. Yes. Yeah. I think it was really clear from the feedback that they given that it was really good being able to get local support early, local to them, and that linked in with the school and with their network as well, and that they would link in with specialist mental health to ensure there's a smooth transition if there was an escalation in needs. So at the end, no door is the wrong door. I've included some performance data in terms of waiting times, so it's quite small to be able to see that. But in terms of our we kind of measured in terms of referral to treatment times. So as you can see in Warwickshire North, for the different levels of referral to treatment times, so emergency, urgent and routine, the service has been meeting all the targets in terms of 100% being seen within those treatment times. Where there is some slippage, and I think we spoke about this last time I was here, was in those follow-up appointments. So after you've been seen, then your second appointment, being seen within 12 weeks, which is a locally based target, there is some variation in terms of how we are meeting that target. But in terms of work that we're doing, I think collectively, we've got CWPT have a waiting times meeting where we talk about all the waiting times across Coventry and Warwickshire, and we go into some depth around who are those young people who are waiting a long time, particularly for those follow-up waits, so that information is shared around what support is available, what support has been offered for those young people. So we've got more intelligence about what's happening for those young people who are waiting long times for their follow-up appointments specifically. As you're probably aware, the RISE contract is an outcomes-based contract, so I've tried to include some of the outcomes information. So we've had over 2,000 children and young people access direct services in Q1, and 88% have reported a positive outcome. For our children looked after, we've had 61 children access support in Q1, with 100% of those young people reporting a positive outcome after their involvement. Sorry, if we go to the next slide. That's some more detailed information in terms of the RISE reporting. So it's split between CWPT CAMS referral to treatment times, which is what we call our core CAMS, so that's the specialist support. And then CW Minds, they provide our what used to be our tier 2, so the lower intervention, so that you can see the waiting times are slightly different across those. Again, the second point around the first 2 appointments, I'm drawing your attention to the 140 days for the mind, emotional wellbeing groups. That is something that we're picking up within the waiting time meetings and really looking at how can we drive down those waiting times in particular, because they are quite excessive at the moment. But I suppose what I would like to get across is that we're using the waiting time meetings to really understand what's happening and to target resources as needed, because we've got a much greater focus on those waits and a much greater detail.
I think it's fair to acknowledge that the waiting time meeting in the way that commissioners and providers are sitting together to talk about joint solutions rather than perhaps an historic contract arrangement is considered to be sort of something that is seen as best practice. It was acknowledged by the QNCC, the Quality Network for CAMS, as being something that they don't see around the country, and it is about us trying to share that. There aren't any necessarily easy answers to some of those wait times, but actually by having a joint forum where we aren't in a contracting arrangement, this is about, these are the difficulties that we're having, how do we find and look for solutions, actually is considered to be good practice.
The second part in terms of performance, I know there's been a lot of focus, particularly locally, around our autism diagnosis. With kind of core CAMS as referral to treatment targets, there isn't at the moment with autism diagnosis waiting times. But just to kind of paint the picture, the average waiting time in North Warwickshire has increased in the last year from 44 weeks to 52 weeks, with the longest wait being 192 weeks. Wanting to emphasise as well that the number of referrals that we are receiving for young people needing an autism diagnosis far exceeds the clinical capacity that we currently have at the moment. That being said, it is something that is a focus at the moment. We know that 192 weeks waiting for a young person for a diagnosis is not good. It's not good for that young person. So we've been doing some work around aligning the preschool and school age pathway, and CWPT have also continued to purchase additional assessment capacity from St Andrews Healthcare to try and get through some of those assessments that are coming through. There are commissioning developments around ASD. An awful lot of work has been going on in terms of understanding what the needs are. There have been some walk and talk, so meeting with families and young people and young adults with ASD to understand from their point of view what works and what doesn't work for them, and to really understand what the needs are. That's being pulled together with an all-age autism strategy, so to understand and to look at what services are needed, and to also we're looking at a needs assessment around ASD as well. So it's been a number of years since we've had a needs assessment around understanding what the ASD needs are in our authority. The final bit was around children in crisis. This was another question I think that came when I was there last time. So there's been I think it's fair to say, a significant amount of work and significant investment as well in terms of looking at children in crisis. And those requiring Tier 4 inpatient beds. So 3 CCGs have put in additional funding to extend the acute liaison team in our hospitals. So that is now a 7-day-a-week service, working from 9 till 8 p.m. And then the second phase of that investment was around developing a home treatment service. So I think, as some of you may be aware, we haven't got any Tier 4 inpatient beds within Coventry and Warwickshire, so all our young people go out of county, which significantly impacts on their outcomes. So what this service is trying to do is divert young people from needing Tier 4 beds and enabling them to have treatment at home, so keeping them close to their families, close to their networks, close to their schools, and close to the local services as well. Transforming Care has also been doing a significant amount of work in this area. So they've been piloting an intensive support service for young people with ASD and ALD. We've also got a pilot autism support service, which is providing pre and post diagnosis support. So you don't have to have a diagnosis to receive that support. And that support is both for children in the sense of youth clubs and things like that, but also for parents in terms of supporting their young people with their needs around ASD. Some of the work as well has been specifically in terms of reducing the number of young people in Tier 4, and wanted to report that the numbers in Tier 4 for Transforming Care have reduced from 15 to 8 across the STP, so that's across Coventry and Warwickshire, and then 5 of those young people are from Warwickshire. So that's a significant reduction in the number of young people who are in Tier 4 inpatient beds. There's also been significant work around self-harm within Warwickshire, so led by Public Health, bringing together colleagues from across the system, so education, health, social care, statutory and third-party organisations, to look at our responses to young people and adults who are self-harming. And that's been feeding into the local council working group that is also looking at self-harm and suicide awareness. So as you can see, there's a number of things that have kind of been going on, really. It's been a busy year since we last saw you. So hopefully that answers some questions, but I'm sure you have a few more.
Thank you. We've just got one speaker, Michelle, come to the floor first, and I'll take notes.
Thank you for your presentation. I mean, it's concerning, particularly like the autism diagnosis is actually getting worse. I had hoped that with your new system and things would be getting better. I mean, I don't know what the solution is for that, because if there are more children with that condition, you know, unless you've got the workforce and the money to pay for it, I don't know how you get round that. And you're obviously well aware of what the problems are. It's trying to find a solution, isn't it?
I think the positive thing is that because I manage the neurodevelopmental service for children and adults, and whilst the wait is very frustrating, the doors for other support aren't closed. So if that child has any level of mental health or any emotional wellbeing support needs, they can access all of that. So the diagnosis is only that one part of it, and whilst that's, for many people that's very important, the intervention's often the most important thing for some of them. So, and also I think, unfortunately from a government perspective, that money hasn't come in yet. I'm hoping at some point it will, because it's acknowledged that the prevalence is definitely increasing. The awareness of autism and what that means is changed over many years. So I'm hoping that we'll catch up. But a lot of the people we've done the service user engagement with, it's very much about saying, well, I want the support, I want to know I can access a service, I don't want to know that not having a diagnosis is going to stop me from accessing what I need.
Thank you. Councillor Llewellyn Nash?
First of all, I'd like to say thank you for what you're doing. I think this is excellent. And as a mother of a child who had autism, I just wrote down some numbers here. It took me 5 years for my daughter to get statuses and to have extra things put into place. So, you know, to have that down to 3.5 years, basically, I think you ought to be encouraged. And it was a very worrying time for myself and my partner, and we didn't have anything like this that we could access then, and I wish we had. Although you might think that there's so much more that you could do, I think this is an excellent start, to be honest, and I congratulate you. My only concern is, if there is one, is that I understand that community hubs and consultation slots and things, prevention and early intervention, are difficult to have, but there isn't any. I know you've got Nuneaton and Bedworth, but really Bedworth, I would have thought, needs its own hub, its own places for children and parents to be able to discuss, because obviously Nuneaton and Bedworth are both growing, but I know clearly that in Bedworth there are lots of issues. I'm a governor of one of the schools, and they have multiple issues going on in that school at the moment, and something like this would be really helpful. But for some parents to even get to Nuneaton would be a big major thing for them, with transport and other children and everything else. But no, I really think you ought to be encouraged. And at least I think, I've written down here, the doors of support are open for parents now, which they didn't even exist. So take encouragement, okay? Thank you.
I'll just add about them, because that is absolutely something that we've looked at. So we've also been doing some work with Bernardo's and how we can utilise some of their sites.
Oh,
now
okay.
that their contract has moved, hasn't it? So in
Yeah.
terms of a presence in Bedworth, you're absolutely right. We want to replicate the Abbey in Bedworth, but it's always finding venues. That's the biggest challenge. But our work with Bernardo's is already at that point where they're saying, you know, our doors are open to you to access and support as well. So that will be part of our next journey.
Excellent.
So, yeah, you're absolutely right there.
Okay, thank you.
Councillor Goldie?
Yeah, to pick up on the waiting times, 192 weeks. Was that quite a specific set of circumstances that led to that really, really long delay?
Unfortunately, no. The referral rates for North Warwickshire have maintained over the last 12 months have been quite significantly high, and our clinical capacity has remained static.
Yeah.
So what we've got capacity to do assessments for is more than 50% less than actually what the referral numbers coming through the door.
Yeah.
In part because it's such a specialist workforce as well. It only takes one person to go on maternity leave and you've lost 50% of your clinical resource really. That's why we're using St Andrews to backfill the maternity leave. It's just very fragile because it's such a small workforce. There was some investment 2 years ago, but again it's the equivalent of like four assessments really.
Yeah.
Because it's not just one appointment for an assessment, for a diagnostic appointment, you need to have a couple of assessment appointments really to make sure you're making the right judgment, because it's something that stays with you for life, so you have to get it right.
So that kind of leads me on to a couple of the other questions that I've got is, there seems to be a marked increase in autism, requests for autism diagnosis. Have you noticed that there is a lot more of a need for autism diagnosis? And are you getting high volumes of children that are sent for diagnosis that do actually require diagnosis, or is it just we don't quite know what to do with them, put them in that queue? If you know what I mean,
Yeah,
not to belittle anything,
let's
but
rule out
are we
autism
actually
before we rule out
are
anything else.
the right people being directed to the service? Is what I'm trying to
I would
say.
say yes, only because we have a really robust referral form which parents and school complete. So we make, because what we were really worried about is a child sitting on a waiting list for however long years and then getting to the point where they're assessed and saying, oh dear, that was the wrong one.
Yeah.
So they are triaged by mental health initially anyway, all referrals. So if there is anything that's indicative of mental health, they would also go to there as well as our waiting list.
Right.
So that's a reassurance. Our diagnostic rate is 70%, and that's not to say that 30% didn't need an assessment. They were relevant, they were appropriate. Often autism is presentation is very clear in terms of with some children who have maybe attachment disorder or difficulties or social communication difficulties, but doesn't fulfil the whole criteria for autism. So we don't feel that children are coming through that aren't appropriate, which is reassuring. The prevalence is definitely increasing, but so is awareness.
Mm-hmm.
With awareness, the more you have a specialist teacher service in Warwickshire who have done training in schools. That happened in Coventry, and the increase happened. And you'll find that some of the best schools who do lots of reasonable adjustments for these children are the highest referrers.
Mm-hmm.
So increasing that awareness will increase the referral rate.
Yeah. So going back to your 70% analogy, the other 30% would still be receiving treatment of something else within your system.
It may be that it's recommended, because every report that we do would have recommendations and acknowledgement or signposting after that. Of course, if it's a social communication disorder, it might be that they're going to speech and language therapy, or if there's anxiety. But many of the children would be receiving that support going whilst they're on the waiting list. They wouldn't wait for the diagnosis to then access that support. Because we have offered pre-assessment sessions as well. We do telephone clinics with parents, pre-assessment, and when we met with the SEN inspectors yesterday, they were saying that the parents are feeding back. That's really helpful. They know they have a wait, they almost accept they have a wait, but they need to know they can get some support in the interim.
Yeah.
So that's why we've provided some of that pre-assessment support.
So people are not just on a list and then
No,
disappearing.
forgotten about.
Yeah,
Yeah,
so
that's it.
That's the thing that we need to make sure.
We just need to, what we're trying to do though is do a bit of a system-wide approach to this, because the pressure on the diagnosis seems to be coming from things like DLA, or from a family's perspective, they think that they need that to get the DLA, or they need it to get to an education and healthcare plan. So we're trying to re-educate and say actually that's not the case. Those are very much needs-based assessments and needs-based provisions, so it shouldn't be about the diagnosis. The diagnosis is the person's right, and it helps them with understanding, the family and the people around them to understand it, but it shouldn't be a determinant of the support you receive. So there's a little bit of that shift that we're having to do in the system, really.
Yeah, so even though the figures look quite horrendous, the people are being seen, and it's not such a...
It's just the
bad
diagnosis
picture.
piece.
Yeah.
The support they can still have.
Yeah, okay, thank you for that.
And I know it doesn't kind of make things any better, but this is a national issue as
Yeah,
well. So our waiting times are in line with what we're seeing nationally as well. I suppose that's what we're trying to pull together, that information to kind of raise that at a national level as well as a local level.
And there remains a workforce issue, so even if you suddenly flooded the service with hundreds of thousands of pounds, actually your ability to find staff that have the skill set to do this would be significantly challenged, and that's something that has to be reckoned by NHS employers.
It's not always about throwing money at it.
And the system-wide approach is important, so if it's not a currency to get access and support within schools, well then actually that can go on. It still raises an issue for diagnosis, but...
Okay, thanks.
Thank you. Councillor Longdon.
I think it's just something that was said a minute ago. I think you'll find if you check out universal credit that that diagnosis is required as evidence. So, you know, that's why people are pushing, and that's the case with universal credit. So I think you ought to check on that. I'm not exactly sure, but that's my understanding. So that's why some people are panicking.
But I will go and check it again.
Thank you.
Things might have changed.
Page 3, it's just something I noticed which was a bit far off. It's probably not to you. Coffee mornings, supporting, understanding and managing challenging behaviour for children aged 4 to 12. All the children I know 4 to 12 don't need any training to be challenging. And anxiety for children aged 3 to 11. I think they should be off, not 4. It sounds like you're training them to be challenging anxiety.
Maybe the better side of behaviour.
Yeah. On page 4, on prevention and early intervention, is that work that's being picked up from the closure of the children's centres? You mentioned Bernardo and that, so I'll just put the 2 and 2 together.
No, this has been within the RISE model since we began the contract on the 1st of August 2017.
That might grow now. Children's centres. On the performance, I was staggered at 4 years. That's far worse than what it was mid-90s. But there again, the awareness wasn't there, you'd be quite right. But I think somebody needs to take the bull by the horns. I don't know who, and say this needs sorted, because it says at the top, waiting times for autism diagnosis, and then children in crisis. Children should not get into crisis because of autism.
It's in the 10-year plan.
Totally unacceptable.
So I'm hoping it's in the 10-year plan to reduce waiting lists for autism, but that's a 10-year plan.
By that time, 8-year-olds, 18.
And I think as a system, there is an acknowledgement of trying to understand the importance of diagnosis versus the importance of intervention, because it is a wait for diagnosis, but that doesn't mean things can't be in place to provide support in that period of time, and that is at the moment a significant part of the work of both the commissioners and of the services that are trying to provide that support.
Well, I know a lot of autistic kids have been, and they're great. You know, they just think differently. That's all. There's nothing wrong with them. Although some people think that they should be smacked in shop do worry if those kids now are not going to be able to access either their diagnosis or the services that they actually should expect, the parents should expect, but not be waiting and sticking your hand out. I mean, some of them being sent to, being advised to go private, and a lot of them can't afford it. This really does frighten me, looking at the way the trend from 44 to 52 and then the 196. That's not the way I would expect these things to go. I'd expect them to go the other way. But I don't know how you're going to sort that, or who can sort it, but somebody needs to get it by. I don't know if we haven't got any powers, have we, Chair? We can only make recommendations, can't we?
That's right.
Can't we send someone to the Health and Wellbeing Board, say, get your finger out on this and get something done? We could do that, couldn't we? If the committee agrees. I'll move that we contact the Health and Wellbeing Board. We're very concerned with the waiting times for autism diagnosis and children moving into crisis, and they need to look at it and get something done about it. I'll move that, Chair, for the seconder.
Does that receive a seconder?
Oh, okay. Everybody cares about the kids. Fine.
I think we've just had an explanation that the staff aren't there to do it. So,
They're not going to be there if somebody doesn't push it.
but they, don't you
Not
think they already
training
are?
Oh, it's all right. You don't care. That's fine. I don't know.
I do care.
Don't say that I
One
don't
more
care.
speaker, Councillor Sargent. Thank you.
Thank you. I've got where I live a great group of mums who have all got children with lots of different disabilities, and what I found by talking to them is actually they can access things and they find it, but it's when you first believe that your child has got something wrong, you're concerned because you've not done. So there's lots of things on social media, obviously, and these groups actually, by talking to other parents, are actually really helpful and can push them in those directions. And it's sort of like those need to grow, and there's lots of it in Nuneaton and Bedworth, which is great, you know. So I think that's a plus thing if they share their things. I mean, people have come to me as a counsellor, I don't know, but I know where to push them. But as sites with or parents that they can talk about it, and they've learnt from, like, you know, over the years that it's changed. And I think that's really good as well, really, and it's good to encourage those sort of things. And if you visit those sort of places as well that have in the borough, I think that would be really helpful.
And it takes time, doesn't it, for things to develop, and certainly some of the things when we have the coffee mornings is exactly that thing, is we help to create those networks as well. So it's, for us, we've seen a significant ask to do this, you know, everybody's saying this is exactly what we want, because it is, you're absolutely right, the first conversation is, I'm not sure, and I think this perhaps possibly needs some support, and actually to get in at that level prevents either not knowing, which causes more anxiety, or jumping straight to a specialist intervention, which still doesn't quite fit, because I think there is so much, like you absolutely right, that can be done at this level.
It's lovely how they talk about the children as well. It's just like,
definitely,
yeah, it's just lovely. It's lovely to see. I see it on the social media site that I'm on. It's lovely to see. The hard bit is obviously what they're going through. So so and so's kicking off something. You know, that's hard to read, and how they cope with that. And then but then another one will say, well, mine did that. Why didn't you try this? So it's all, you know, it's just the networking, which is great. So keep it up. Nice seeing you again. I was here last night. I think you've been in work 2 days or something.
Yes.
Thank you, Chad.
Councillor Rudd.
Sorry, I don't need to put you on the spot, but you mentioned about the servicing, the same service coming to Bedworth. Is there a time frame for that? Because obviously Bedworth
it will happen pretty quickly, because the biggest work was doing the service level agreement with Bernardo's, so that bit has been done. So we had a meeting Friday just gone where we can now start to access. So yeah, the conversations have already been happening with Bernardo's. We had to wait for their contract, so they've only just started their new contract.
Yeah.
So now that theirs is in place, then we can start.
Yeah, I didn't mean to put you on the spot, but obviously it's for Bedworth.
We do go to the schools in Bedworth though, quite a lot. So there were 9 schools of the North Warwickshire area, including Bedworth, that we went into that Q1. So So a lot of the schools we have some really good relationships with. So sometimes when we're in that school, we're doing consultations, we're seeing the parents by default as well. So that I don't want people to think that we're not in Bedworth. We just haven't got that whole setup in Bedworth, but we will do. Yeah.
I work out of a hub in Coventry, and I appreciate the work and that goes into it, and the signposting that's there. So Bedworth really does need. So, yeah. Okay, thank you.
Okay, thank you very much for your time. Thanks for your presentation. Very informative. Thank you.
Thank you.
Sorry, we can't help you anymore.
Okay, moving on to agenda item 9, forward plan. So this is on page 67 for information only. Yes, Councillor Evans.
Chair, I'd like to make a brief comment, if I may. And this is with regards to the feasibility study in leisure provision options. Now, it says here the date it's going to be received to Cabinet is December 2019. Now, we were told that this was 12 months ago that we'd have this report in front of us in the summer of this year. Philip Richardson keeps on pushing it back every single month, and it's starting to frustrate me because I have constituents. I probably get about 2 emails a month about Bedworth Leisure Centre complaints. And I'm only, all I can say is, you know, there's a feasibility study that's going to be released soon, and every time it gets on being pushed back by Philip Richardson all the time, it just annoys me because I can't give proper answers to my constituents. So, I mean, I have my suspicions as to why it keeps on being pushed back, but I won't put those on public record.
Just to clarify, Councillor Evans, sorry for interrupting. Correct me if I'm wrong, Wendy. I believe this is going to internal on the 14th of November.
It is.
Yeah. So it is going on the 14th of November.
But you cannot go to an overview of scrutiny panel before going to Cabinet, I believe. I believe Cabinet has to agree that it's got to go to an OSP for scrutiny first before they approve it.
And you can have pre-decision scrutiny.
Right. Okay, well, regardless, I bet you £5 that won't go to A, the 14th of November, or B, Cabinet in December. So can we have, because I'm 100% guaranteed it won't go to either of those two committees, can we have Philip Richardson come into the next external OSP, which I believe is on the 5th of December, to come and sit here and tell us why it keeps on being pushed back all the time? And I move that as a recommendation as well, actually. It's starting to annoy me a bit.
Does that have a seconder?
Sorry, what was that?
Does that have a seconder?
I'll second that.
Go on then.
Yeah, it's seconded.
So, providing that it hasn't been to internal on the 14th of November, the request, just to be certain, is that Philip Richardson attend the next scrutiny meeting.
Yeah, to explain why it keeps on being pushed back.
Okay.
Vote
Yeah. All those in favour?
Oh, sorry. It is going.
And against? And any abstentions? Thank you.
I've got one more as well. I won't move any votes on this one, but it's just an observation. There was an individual cabinet member decision 2 weeks ago about the concept plans for the borough plan. This should be part of the forward plan because it's got to be approved by cabinet apparently, but I also believe it should then go to council for a vote to full council, but apparently that can't be allowed. Don't ask me why.
Okay, moving on to the last item, work programme on page 71 and 72. So again, it's for information only. I've got a couple of points to make on page 72. So specifically regarding the gambling and the changing places working group. So we're still requiring some volunteers to sit on those panels. I believe we need a replacement for the gambling one, and we're looking at some volunteers to sit on the panel for the changing places. So happy to take any volunteers around this committee first. Failing any volunteers from this committee, we will then send it out to all members.
I'll do the changing places. So we're waiting for an email actually to verify that. But yeah, I'll be on the changing places one.
Okay, fantastic.
That was brought up 2 meetings ago,
Yeah.
2 or 3 meetings
The
ago.
email did go around.
They had it then,
Volunteers.
there was a few put their hands up.
I've never had one before.
Councillor Rudkin responded to it, so it did go out. I can send it again, but I'll make a note that you put yourselves forward.
Yeah.
Chair, I'll sit on the changing places one. I won't go on the gambling one because I don't know anything about that
I'm
myself.
giving you past record.
Yeah, you just bet everyone if
And it stands.
Wendy, was Andy on any of those? Because I think he put himself forward for one, but I don't know which one.
Gambling.
Gambling.
Well, I'm
Did
just
he?
saying that.
No,
I'm just
I
putting him on it.
I think it might have been because he was
I think
talking
it was
about
on
the
about,
gambling
it was
one,
something,
yeah.
it was something that came up with county as well, and he was on about it. So
Something
I'll
on
get
the
him to email
internal
it, because I
recipe.
can't speak for him obviously, but I'll get him.
Thank you very much for volunteering for that, thank you. I'm not aware of any other business. So thank you very much for your time and contribution this evening. Having a safe journey home.
Thank you.
Thank you, Chair.